comorbid depression by Dr. Mohammed Zaveri. Please welcome Dr. Zaveri. Thank you for the introduction. So the topic at hand today to be discussed is an alternative approach to managing diabetes with comorbid depression. Reflecting through the literature, our team learned that diabetic patients with comorbid depression have a higher healthcare utilization and poor clinical outcome. They often struggle with self-care and have a difficult time adhering to treatment guidelines. Many of us here are family medicine practitioners, as pointed out by Dr. Tarn through the survey that we did briefly. So some of the challenges that we face may revolve around having time constraints or scarce resources in the primary care setting. Quite honestly, a number of us struggle to adequately provide support and education to our diabetic patients. We even go on to miss that assessment of depression or to even spend that sufficient amount of time required to set self-management goals with our patients. Therefore, diabetic patients have just too many issues that can't be addressed during the traditional 15-minute visit. A recent study supports these statements by concluding that more than 50% of diabetics receive limited or no care with regards to diabetes self-management education. Research also goes on to show that effective diabetes self-management education and support can improve clinical outcomes and healthcare costs. Therefore, to further explore this topic, a group of family medicine residents, co-led by clinical psychologists, pursued to determine whether group collaborative care visits were an effective intervention to improve self-care in diabetics with comorbid depression. It was a prospective study conducted on a sample of 40 patients, randomly dividing those patients into a group of each 20 into a control group and an experimental group. The control group patients went on to have routine visits with their primary care physicians. In contrast, the interventional group met with a team of family medicine residents and a clinical psychologist for 1 hour a month over a total period of 6 months. During group sessions, the team provided diabetes and depression self-management education and support, along with assistance in setting goals with the patients, and in the process, the team was able to record goals that were set by the patients and those goals that were attained by our patients. Baseline and end HbA1c, LDL, and BMI values were measured for both groups. Along with that, baseline measures and demographics were quite similar among both groups. Coming to the results on these next three slides that we have set up, you can note that there's a strong connective correlation between self-management goal attainment and improvement in diabetes quality measures. This bar graph here, if you take a look at these measures, the diabetes quality measures that were measured for the experimental group, there was a change that was recorded averagely between the base values at the initial point and at the end of what was the value. So it can be noted here that the HbA1c values decreased for the experimental group. There was also a decrease in the BMI values, and then there was also a reduction in LDL values for the experimental patients. Using the odds ratio, the average reduction in HbA1c was noted in the experimental group. The initial value of HbA1cs at the baseline was noted to be 8.83, and that there was a reduction to 7.96. That significant value amounted to be about 0.88. So overall, there was about a 1% reduction in HbA1c value, which proved to be statistically significant. This next bar graph here shows diabetes goals attained by our experimental group. You can see that the most common groups that were set were trying to lose weight, trying to take medications regularly, and trying to be physically active or exercising. It can be noted here that 50 to 60% of the experimental group were able to attain goals set for diabetes. On this next and last chart, it illustrates depression goals set by the experimental group. In this group, the most common goals that were set included making time for pleasurable activities, along with making time to socialize with supportive people. It can also be noted here that there was a full achievement of 50 to 60% of depression goals set by our experimental group. Therefore, it can be concluded that group sessions can be effective in helping diabetic patients improve diabetes quality measures. This study allowed us, the researchers, to step into the experiential world of the patients and view firsthand the development of connections between different patients, yet similar diabetes with comorbid depression. It allowed the unique observation for us, the researchers, to view the hidden or concealed perspectives of the patients. Some patient outlooks that were viewed by the group and the research team worth mentioning included a chemotherapy-receiving patient fighting cancer, a self-struggling adult taking the time to make time and take care of his infant grandchild, and even a young individual who was inflicted by an orthopedic injury, all throughout group collaborative care interventions. Over time and through interactions, the patients came to discover that each and every member of the group was struggling with some sort of problem related to life. With that, the group went on to imitate a collaborative approach, which was held by asking the patient at hand with the problem to work together with the group and jointly come up with a solution. Those individuals that made progress within the group were able to instill hope for the entire group. Some of the limitations that were noted in the study included the sample size, the length of commitment, the socioeconomic status of the patients. Many barriers tied in well with the socioeconomic status, including like transportation issues for the patients to come to the hospital to be a part of the intervention sessions, along with financial situations, being depressed, and even family or social problems. Therefore, in conclusion, diabetes group visits were effective in improving quality measures like those shown, for instance, in HbA1c values, BMI values, and LDL values, along with a high attainment of diabetes, and depression self-management goals. Group education, shared problem solving, and individualized goal setting were able to uniquely activate patients in caring for themselves and in the process achieve glycemic improvement. As the healthcare model moves away from volume-based care more towards quality-based care, it was noted that group sessions with a focus on individualizing care improved diabetes healthcare outcomes.
So we have time for a few questions. Over here.
My question is regarding matching of the groups.
At the end, you mentioned that there were
some of the limitations of the socioeconomic factors. Was there were the A1Cs matched at baseline between the control and experimental group, or certain numbers or values specifically matched across the groups?
They were matched at baseline. Those values did not seem to be statistically significant. Like I mentioned, the experimental group had about an average A1C at baseline of 8.83. The control group was around 8.6 as well. So there wasn't much of a difference, no.
And in terms of the socioeconomic or some other stresses, was there any control? I know that at the end of the day, N of 20, I mean, you can't match everything. But
as far as socioeconomic status, that's a good thing to look into, but there weren't many significant changes that we noted, nor did we collect information mainly focusing on the socioeconomic status. So that's one thing that we can look into again, but I don't think it would have made a big difference in the outcome.
Any additional questions? Thank you so much, Dr. Zaveri.